Well, it's 10 o'clock, so we have a busy schedule to keep. We have to get through 9 presentations this morning. So my name is Richard Anderson. I'm going to be one of the moderators. So I'll announce it now, but just so everybody knows, every paper but the last paper is actually a candidate for best paper by a resident or surgeon in training. And I'll try to remind you of this for those who are going to be voting. So our first paper in this session is entitled Interventions and Outcomes After Surveillance Imaging in High-Grade Liver Injury Patients. Doctor, and please help me, is it Hogu? Gu?
I'm here to present on the utility of surveillance imaging in high-grade liver injury patients. Thank you all for your time. Is this my slide advancer? Got it. Thank you so much. I have nothing to disclose today. So we know that high-grade liver injury, specifically referring to AAST grading classification of grades 3 through 5, carries with it, even after much technological advancement in the management of these injuries, a high risk of both mortality and morbidity. Unfortunately, for those who do survive these injuries, there's a high risk of life-threatening complications after injury, including pseudoaneurysm, bile leak, and abscess. And so some clinicians use the modality of surveillance imaging, generally with computed tomography or CT scan, to catch these complications early and using the presumption that early detection will help prevent morbidity. Current AAST and EAST guidelines are vague about surveillance imaging in this patient cohort, and offer that it should be used in select cases without a lot of granularity about which cases those might be. And there's been plenty of disagreement and a lack of consensus in the literature about this question, with certain studies concluding that surveillance imaging does not detect complications at a sufficient rate, but those studies often being done in a retrospective nature with highly heterogeneous samples and definitions. So here we have a gap in the knowledge that we aim to study. Specifically, we ask how successful is surveillance imaging, or SI, in detecting problems requiring intervention, and secondly, preventing unplanned intervention, which we feel represents further complication after imaging, as well as post-discharge complications. And compared to repeat imaging prompted by clinical status change or no repeat imaging. To do this, we identified adult trauma inpatients between 2018 and 2024 with high-grade liver injury in our level 1 trauma center's trauma registry. We excluded children, deaths under 24 hours, and transfers. And we then conducted a rigorous manual chart review to first categorize patients by their imaging type, either clinical imaging, surveillance imaging, or no follow-up imaging, and then identify sequela, so imaging-based interventions or the detection rate, and then unplanned interventions or later complication rate. And then we noted later complications or post-discharge complications, namely readmissions, ED visits, and mortality. We found 322 adult trauma patients with grade 3 or higher liver injury, and from those, we found 64 of those patients died in less than 24 hours. That's still a pretty substantial, almost 20% mortality rate from high-grade liver injury. 6 were also excluded for transfer. That left 252 patients included for study. Of our included patients, the wide majority were male. The median age was 28. We had a pretty even split between Black and white patients representing our urban trauma center population and a 7.9% Hispanic population. Over half were grade 3 injuries, 37% were grade 4, and 8% were grade 5. Noting again that this is after survival of 24 hours. First, we found that injury grade does strongly associate with differences across many characteristics, with grade 5 patients most likely to have penetrating or gunshot wound mechanisms, go to OR or IR early from the ED, receive MTP, have longer hospital and ICU stays, and have unplanned interventions. For our first set of results, we looked at how and when follow-up imaging was used. Specifically, we found about 50% of our cohort had no follow-up imaging, and then about a quarter each had surveillance imaging and clinical imaging. We did find significant differences between imaged and non-imaged populations. So in particular, we found that the surveillance imaging and clinical imaging, the imaged population had higher rates of grade 4 and 5 injury. We found they were more likely to have penetrating mechanisms. They were more likely to go to surgery within 48 hours of their admission or to go to IR within 48 hours of their admission. Their length of stays were generally longer at 13 and 12 days for CI and SI respectively versus 5 days for non-imaged patients. And we found that ICU length of stay also was longer for imaged patients. ED visits were more common in imaged patients than non-imaged patients, and mortality was higher in imaged patients than non-imaged patients, although that one was trending towards significance with a p-value of 0.07. So in general, this reflects that imaging was used appropriately in more complex patients. We then found that these differences weakened when we compared the surveillance versus clinical imaging groups head to head. There were no significant differences, but there were some differences trending towards significance, specifically hospital length of stay, somewhat longer in clinical imaging patients, and the ED visit rate was marginally lower in surveillance imaging patients at 30% versus 43%. We then looked at the success of surveillance imaging in particular in detection and prevention. We found that surveillance imaging led to intervention in 10% of cases, while clinical imaging led to intervention in 30% of cases, and this was a significant difference. We also saw that 18% of patients with SI had later complications versus 37% of patients with CI. So SI patients had fewer complications and in particular, fewer later percutaneous drains placed. In conclusion, surveillance imaging in high-grade liver injury is associated with lower rates of unplanned intervention or complication and marginally lower rates of 90-day ED visits. We also find that patients without follow-up imaging at all had shorter and less complex courses than those with imaging, suggesting effective use of surveillance imaging and clinical imaging. In conclusion, we do feel surveillance imaging does have a detective ability at a 10% detection rate in this cohort, but that its power does really need to be studied prospectively in order to make meaningful conclusions, because the categorization of surveillance versus clinical imaging is in itself a source of selection bias. So we thank you for your attention for this presentation, and I'm free to take any questions.
This discussion will be opened by Dr. Dahlman.
Hi, good morning.
Good morning.
The authors present an IRB-approved retrospective evaluation on surveillance imaging with high-grade liver injuries from a single site database. I have 5 questions. There are discrepancies in the manuscript regarding the number of patients evaluated versus the results listed in the tables given in the manuscript. It is stated there are 252 patients, but there are only 250 listed in the tables. Upon closer review of the data results, there are many differences in the numbers listed and seemingly errors in data evaluation. Examples for the massive transfusion protocol group, the grade 5 injuries were 5 of 22, which is 22.7%, not 31. Grade 4, 14 out of 94, which is almost 15%, not 19%. And grade 3, 3 out of 134, which is about 7%, not 9. This caused me some pause and concern about the validity of your statistical analysis done throughout, but perhaps it's due to other exemptions, criteria that you didn't explain in the manuscript. Number 2, although it's a database study, it is your data. Do you have information on ISS or other injuries? as I assume that liver injuries are not in isolation, that are associated and their outcomes, as this may change your data, where sicker patients have more injuries, thus for more imaging, et cetera.
Mhm.
Number three, overimaging is a healthcare burden. Do you have data on cost if you did not perform any of these imaging tests? Number four, based on your findings, it seems that a simple algorithm can be created as to who needs close follow-up surveillance imaging and who does not. Have you looked at this as a possible performance improvement project? Because it is your data. And number five, there is discussion on clinical imaging needs versus surveillance imaging needs and how this is a bias, as clinical imaging can serve as a proxy for illness severity. However, the paradox of no mortality for grade 5 injuries is not addressed. Can you explain this? Overall, I enjoyed your manuscript and I appreciate you sending it to me well in advance of the meeting.
Thank you.
I await your responses. Thank you.
Thanks. I don't have a pen, so I tried to memorize all of those. So please excuse me if I need a prompting, but I'll try to go in order. Your first question was about numeric discrepancies in the tables, which we had the opportunity to discuss. Our tables did utilize or our statistical analysis used available case analysis, which basically means there were some level of missingness in every data point because this was a manual chart review. So data collectors were able to leave any variable blank if they were not able to find the information needed. And so the initial discrepancy that you brought up, 252 versus 250 patients, is referring to a breakdown in the patients by injury or by grade of injury. And that table I actually didn't include in this presentation as it's basically my first demographic table. And 2 patients were left out of that calculation of injury grade because their data points for that variable were entered as free text, like someone typed in 3 instead of putting in the number 3, and so they weren't translated to the statistical analysis. And then there was missingness for every collected covariate, including MTP. So about 60 patients, if I recall, did not have MTP findings per our data collectors. And so the percentages refer to the patients that do have data versus the whole cohort. So that kind of, I think, every discrepancy that you mentioned is accounted for by data missingness. Your second question, I believe, was about injury severity. Thank you for bringing that up. I did not include it in this presentation, but there were differences in severity by grade and by imaging status, and they were expected. So grade 5 patients had much more severe ISS than grade 3. On average, it was 42 for grade 5 and 19 for grade 3. While the same kind of scale of severity did apply to the imaging groups as well, also as expected. So in line with what we saw, that people with no follow-up imaging had less severe injuries with a median of 20. People with clinical imaging had the most severe injuries with ISS of 35 on average. Your third question was about cost, I believe, cost analysis. So we did not run that in this study. I think that's a brilliant follow-up idea and one that I'm very interested in. We generally did like shorthand math to think about this. CT scans cost on average $800 in our hospital. So if we think about 50 patients out of 60 not having findings on their surveillance imaging, that puts us at about 5 times 800, so $4,000 of missed cost. But it's hard to do a comparative analysis, obviously, without the full morbidity costs of those who would have had missed injury without surveillance imaging. Your fourth question was about developing a protocol for imaging. This is something we were very interested in when we set about planning to do this study. And we wish that we found more consistent characteristics among the patients in whom surveillance imaging was successful. But we had a very small cohort. We had 6 patients in whom surveillance imaging was successful. They had a wide range of mechanisms. Half were blunt, half were penetrating. They had a wide range of grade. Half were 4, one was 5, and 2 were 3. They had a wide range of complications that were detected. 3 were drains, 2 were angioembolizations, 1 was an ERCP. So based on this heterogeneous sample, we could not make any conclusions about the patient profile in whom SI may be more useful. But to the point of my last slide, future studies should just, I think, be prospective and randomized so we can gather more data on this front. And our department is interested in that question because right now, actually, exactly about half of our trauma surgeons use surveillance imaging and half think it's not useful. So it actually is a kind of useful way to test this. And then your last question was about the lack of mortality in the grade 5 patients. This is really interesting to us. That's why I called it out in the manuscript. For us, I think part of it is that the severe grade 5 injuries, they're all severe, obviously, but the ones in whom the injury would be fatal all died within 24 hours. The wide majority of those first 24-hour deaths were grade 5. And so to us, this was an interesting kernel of something that if grade 5 patients are to survive their first 24 hours, they may be more likely to survive in general overall. I think that was all your questions.
We have time for one very quick question.
Thank you.
Sachs from Indianapolis, great paper.
Thank you so much.
Was really interested in, of your SI patients,
Yeah.
did any of them have other clinical indicators that would have led you to a clinical, getting an ERCP, their bilirubin must have been up.
Yeah, they actually didn't. The ERCP was the one that we were the most surprised about. We rechecked truly all of these charts many times, and I think that was really one of the most difficult parts of this study is that the definition of surveillance imaging, pure surveillance imaging, is hard to enforce. And so we rechecked, especially the ones in whom surveillance imaging that then led to an intervention was noted by our data collectors who are all medical students. And we did find in this patient, this was a very early fluid collection in the area of the liver that had not yet transpired in the sense of labs or signs and symptoms. So that was really interesting to us. We weren't expecting to see that. And in general, yes, we did try to enforce really, really strict definitions that surveillance imaging had absolutely no signs or symptoms prompting that imaging being ordered.
Thank you.
Thank you.
Good morning, I'm Maggie Brandt, and the next paper is also Best Paper by a Surgeon in Training Award nominee. Sound the CRRT alarm, hyperphosphatemia as a biomarker for renal failure after trauma and development of the risk for renal replacement after trauma score. Meredith Hazelwood from Wayne State University.
Good morning. My name is Meredith. I am a third-year resident from Wayne State University, and today I'll be talking about hyperphosphatemia as a biomarker to predict renal failure in our trauma population, as well as our development of the risk for renal replacement after trauma, or R3T score. I have no disclosures. So for a bit of background, as we know, acute kidney injury is one of the most common complications after a trauma admission. Prior studies have identified that up to 25% of trauma admission patients experience an AKI during their hospital course. But despite the fact that it's one of our most common complications, it's very rare that these patients require renal replacement therapy. Prior nationwide studies have identified that it occurs in less than 1% of all trauma ICU admissions. It's a little bit higher in our study population, as we'll get to, but still quite low. And prior studies have done a good job of laying out risk factors for acute kidney injury after trauma, but not necessarily identifying those patients that will require renal replacement therapy. So as we know, the main mechanism by which patients experience hyperphosphatemia after trauma is due to tissue injury or ischemia resulting in cell lysis and release of phosphate into the serum. Phosphate is, of course, filtered in the renal glomerulus. So if a patient has acute kidney injury after their initial traumatic injury, any renal dysfunction can result in persistently high levels of phosphate. So with our study, we wanted to assess whether hyperphosphatemia itself was associated with increased risk for renal replacement therapy. And in addition, we wanted to create a scoring system that might predict those patients that would eventually progress to requiring RRT. So in terms of our methods, this was a retrospective chart review study. We looked at all of our trauma patients admitted to the surgical ICU at Detroit Receiving Hospital from 2013 to 2022. And that we started out with about 3,600 patients. The primary endpoint that we were looking at was initiation of renal replacement therapy within 14 days of admission to the hospital. And then for our process of developing the R3T scoring system, we divided all of the data into odd and even years. The odd years was used as our derivation set, with the even year patients being used as the validation set. Then we used an area under the receiver operating characteristic curve to assess basically the fit of the data. So as I said, we started out with 3,500 patients, and our exclusion criteria included existing CKD or ESRD because that would definitely confound our data. We removed patients admitted to the hospital under 72 hours, patients admitted to non-trauma services such as SICU or MICU, as well as pediatric patients. We also removed our burn ICU data and ended up with about 1,600 patients, 54 of which, or 3.3%, would eventually require renal replacement therapy within the first 14 days. And our median initiation of renal replacement therapy was hospital day 4. This chart, we're just looking at characteristics between the patients that would ultimately require RRT and those that would not. Everything listed here was statistically significant between the two populations, with the exception of operative intervention. There was no difference there. So this first chart, the top line is looking at serum phosphate levels of patients who would require RRT, and the bottom line is looking at the serum phosphate of patients who would not. So as you can see from presentation through hospital day 4, it remains elevated. This chart, so the blue bars are looking at our patients with hyperphosphatemia and the rates of which they would require RRT, and those very small gray bars are the patients that needed RRT that did not have hyperphosphatemia. And then here we are looking at the rates of renal replacement therapy with persistent hyperphosphatemia. So as you can see, patients whose serum phosphate never recovered just progressed and were more and more likely to require renal replacement therapy. So this is looking at the development of the R3T scoring system. So just broadly looking at the two different subsets of patients, were there any significant differences between them? The only two that we identified that were statistically significant were BMI and the injury severity score. And then this is what we eventually landed on for our R3T scoring system. The most points were awarded to patients that had hypotension, specifically requiring massive transfusion or vasopressor support, as well as patients with urine output of 0.375 cc's per kg per hour for at least 24 hours on hospital day 1 or 2. And the total possible score was 15. So here we wanted to assess and make sure that our data was good at predicting, or our R3T score was good at predicting which patients would progress to RRT. So if you're not familiar with it, the receiver operating curve basically takes a look at your true positives versus your false positives. And ideally you want a curve that hugs the top left corner of the graph with a score as close to 1 as possible. And our score ended up being 0.94. So basically the R3T score was very good at predicting which patients would require RRT. And our graph on the right-hand side basically is we applied the R3T score back to the patients that eventually required RRT. And it was very good at predicting which ones would require it. As you can see, as the R3T score increases, so does the rate of RRT. So in general, just some of the basics when we looked at the R3T scoring system, the median score was a 2, so quite low, but again, only 54 patients in this time period required renal replacement therapy. No patients with an R3T score under 4 required RRT. And the rates, for example, at a score of 11, 71% of these patients would go on to require renal replacement therapy, with 100% of patients requiring it at a score of 13 or 14. So in conclusion, Hyperphosphatemia was associated with increased risk for renal replacement therapy after trauma. Of course, serum phosphate is something that's readily available. It can just be a cheap and easy to obtain part of the patient's everyday labs. The next steps would be a prospective validation of the R3T score. It would be nice to try to apply it to our future trauma admissions and see whether or not it does a good job of predicting RRT. And then lastly, our limitations. Of course, this was a retrospective review, so there were some issues with accurate recording of urine output and, in the early portions of their patient admissions, as well as we didn't always have a serum phosphate on presentation. This is a single center study, of course, just performed at Detroit Receiving Hospital. And then it was a rare outcome. Out of the 1,600 or so patients in our data set, only 54 progressed to needing renal replacement therapy. These are my references, and I welcome any questions.
Our discussant is Dr. Sachs from Ascension St. Vincent in Indiana.
Yeah, thanks very much. This is a really interesting observational retrospective study on the prediction of the need for ongoing renal replacement therapy in patients with persistent hyperphosphatemia. The authors in a well-written paper have demonstrated that hypophosphatemia is an independent predictor for the need of renal replacement therapy in injured patients. The paper also seeks to develop a scoring system, which is a work in progress, to help predict the need for RRT in injured patients. I'd recommend the paper to the members, and I do have a couple of questions. So what prompted this study? Was it just something that was an interesting observation, or was it a surprising finding in a patient who needed RRT? And does following phosphate add to what you already know, or does this observation simply confirm an already obvious course? Thanks for the privilege of reviewing your manuscript. You got it to me in a good time. And I really look forward to further work from your group. And you answered my third question, which is, has it changed anything?
All right, thank you, Dr. Sachs. So for your first question, it wasn't necessarily an unsurprising finding. We had noticed that a lot of our patients with severe AKIs, such as KDIGO3 AKIs, or patients that ultimately needed renal replacement therapy, they did have persistently high phosphate levels. However, we didn't necessarily have the data to prove that that phosphate would then correlate with the need for renal replacement therapy. As for your second question, I didn't have time to get into it with the data. I do think that it will provide some additional benefit beyond what we already know, in the sense that, for example, the KDIGO3 patients that we had, only about 1/3 of those progressed to needing renal replacement therapy, versus with the R3T scoring system, say a patient had a R3T score of 10, that was about 70% predictive of a patient needing renal replacement therapy. So while it essentially makes sense that hyperphosphatemia would correlate with a need for CRRT, it might give us a tool for earlier detection of these patients.
Good morning. Nice presentation and interesting study. I had two questions for you. The first was, do you think the hyperphosphatemia is a sign of renal failure, or is it a secondary finding? Ultimately, what are we looking at? Are we looking at renal failure as hyperphosphatemia, or hyperphosphatemia leading to renal failure? And the follow-up question was more of a comment. The receiver operating curve you have is very nice, and it's good that you tested sort of back on your data set, but I would just sort of caution on sort of taking too many findings out of a small data set and overfitting. Because by looking at your data and then comparing it back to your data, you're going to get a higher number because it's not random. I know that some of that is secondary to the fact that you have a small data set, and there's not really a good database that will allow you to have, RRT, trauma, and laboratory studies, but it'd be something that could be brought to like the Journal of Trauma, or get a calculator on their website for other people to use to validate for you. So just something to sort of think about when you're looking at your data. So the question about hyperphosphatemia.
Certainly, thank you. So with this patient population, it would be difficult to prove one way or the other, but we attributed the hyperphosphatemia after the initial presentation, usually to renal failure, particularly given that the patients that experienced hyperphosphatemia were those with a higher injury severity score, typically more significant injuries, and patients that were hypotensive requiring massive transfusion or vasopressor support. So in theory, we thought that a lot of the hyperphosphatemia was related to the renal failure as the root cause. All right,
Great.
thank you.
Our next paper is positive predictive values of the Afirma gene sequencing classifier for evaluation of indeterminate thyroid nodules and institutional experience. Dr. Lyons.
Hi, everyone. I'm Sarah Lyon. I'm a general surgery resident at Metro Health. I'll be presenting on the positive predictive value of the Afirma gene sequencing classifier for the evaluation of indeterminate thyroid nodules. We have no disclosures. To start, when we think about a workup for a thyroid nodule, we start with a physical exam, history, obtain a TSH value, and then an ultrasound to get our TRADS, which will help risk stratify for surgical evaluation and planning. It was proposed in 2015 and then in 2020 to suggest molecular testing for the indeterminate thyroid nodule. And then in June 2023, we introduced that at Metro Health. The purpose of our study was to examine results of GSC in clinical practice. Our primary outcome was the positive predictive value of a GSC suspicious of cancer. And our secondary outcomes were the specific molecular alterations that were found in patients with GSC suspicious for cancer, and then the thyroid pathology in patients with false positive GSC. As far as our methods, to start, patients that were found to have indeterminate thyroid nodules underwent a repeat FNA 3 months after the initial FNA, and a specimen was obtained for Afirma testing. The results were then classified as positive, meaning suspicious, negative, benign, or no result, which happened when there was inadequate RNA for analysis. We then performed a retrospective study of all the patients with indeterminate thyroid nodules who had molecular testing with Afirma that was suspicious for malignancy, and then they underwent surgery. Here is our study cohort. So our timeframe was June 1st, 2023 to December 31st, 2024. And then we looked at patients that had indeterminate thyroid nodules, and then those that underwent Afirma testing. Patients that had benign nodules were excluded, and then patients that did not undergo surgery were excluded from our primary sample cohort. We ended up with 15 patients that underwent surgical resection. We actually had 16 nodules that were researched because one patient had 2 nodules that were positive. As far as our methods, we looked at demographics, clinical data, and then the results of the Afirma, which include the expression atlas, and then the histopathologic results from the surgery. We analyzed with descriptive statistics. We looked at the true positive and false positive. Then, of course, our primary value, which was the positive predictive value. And we also followed up with patients that had benign GSC to determine if they underwent thyroidectomy. As far as our results, we had our 16 indeterminate thyroid nodules that were suspicious for GSC. The final pathology showed 7 malignant true positives and 9 benign false positives. Our median TIRAD score for the malignant nodules was 4 and 3 for the benign nodules. Here's the chart for the demographic and clinical data. Some important things to pick out. Everyone was euthyroid, and all the nodules were euthyroid. And then our average nodule size was 2.7 centimeters. All of the nodules that were in our study were Bethesda 3 classification. And then 7 patients underwent total thyroidectomy, and 8 patients underwent lobectomy. Our positive predictive value was 44%, with our confidence interval at 23 to 67%. This table shows our molecular alterations, which is the data that we received from the Afirma GSC. The first column is just a nodule number. And then the second column shows the predicted risk of malignancy, which is something that's provided by the Afirma test. And then the expression atlas is the actual genomic alteration that is found. And then the last column shows our surgical pathology from each nodule. And then going more in depth from that table, our expression atlas showed genetic alteration or gene fusion in 8 or 53%. Most commonly, we found RAS mutations in 6 of the nodules, 1 JAK2, and then 1 PAX8. There was no molecular variant or gene fusion detected in 7. And then nodules with RAS mutations were most commonly found to have benign follicular lesions. Our false positive GSC, with the exception of 1 patient with Hashimoto thyroiditis, all patients had benign follicular pathology. And then our benign call rate for the GSC was 63%. We looked at patients and their follow-up between 6 and 24 months and found that 3 patients underwent surgery for thyroid toxicosis and 43 patients did not have to undergo any surgery. And then 1 patient with no result for GSC ended up going through surgery. So in summary, the Afirma GSC has a PPV of 44% for Bethesda 3 thyroid nodules at our institution. The RAS mutations were found to be the most common genetic alteration, and most nodules with a false positive GSC were found to have benign follicular lesions. As far as our study limitations, this is a retrospective study. We had a small sample size. The pathologists were not blinded to the results of the molecular testing. We happen to have no Bethesda 4 nodules, although these, of course, are included in indeterminate thyroid nodules. Ours just all happen to be Bethesda 3. And then the histopathologic evaluation was not obtained for all the nodules tested with GSC. And we can't exclude the possibility of false negative GSC as a contributing factor to the low PPV observed in our study. So in conclusion, we recommend a personalized approach for the operative management of GSC suspicious indeterminate thyroid nodules based on specific genetic alterations. Because of the low PPV at our institution, lobectomy and isthmusectomy is an appropriate treatment for patients with a GSC suspicious nodule without a high-risk mutation and no clinically significant nodular disease involving the contralateral lobe. And I welcome any questions.
The discussion will be led by Dr. DeYoung.
Thank you. So first, I'd like to congratulate Dr. Lyon on an insightful and wonderfully presented paper this morning. This study has educated us on the utility and positive predictive value of genetic testing of indeterminate thyroid nodules in order to decrease the need for diagnostic thyroid lobectomy. So within the past decade, it was actually common practice for most cytologically indeterminate thyroid nodules to undergo surgery, given their 6 to 40% risk of malignancy. But current management guidelines have increasingly included molecular testing as a diagnostic adjunct towards the management of cytologically indeterminate, defined as Bethesda 3 and Bethesda 4 thyroid nodules. So the Afirma genetic sequencer classifier has been helpful to rule out cancer because of a high negative predictive value and has effectively reduced the need for diagnostic hemithyroidectomy. The negative predictive value for Afirma testing for these nodules is as high as 97%, meaning that the molecular testing is reliable if it fails to identify concerning mutations and is reported as benign. But that's not the question that we face this morning. So the definition of positive predictive value is really a measure of how well a positive test indicates the presence of this condition. And the question before us today raised by this study is, can we with certainty identify genomic RNA sequencing alterations through Afirma testing that also reliably predict malignancy when these mutations are identified? The answer from this study and several other larger studies dating back to 2018 seem to say no for Afirma testing, as the positive predictive value is consistently less than 50% in this study and in others. Even the positive predictive value on the Afirma website is only 65%. Simply put, Afirma testing can identify benign nodules with high accuracy when mutations are absent, but cannot reliably identify malignancy in indeterminate nodules when many of these mutations, as is found in your study and many others, are present. So I have about 4 questions. So do you think that the use of any further expansion in the molecular testing panels beyond the Afirma XA, which I think you guys used in your study, will eventually increase the positive predictive value of this tool? Second, have your findings encouraged you to use different types of molecular testing, such as ThyroSeq, which seems to have a higher positive predictive value for malignancy, depending on the nodule characteristics or the clinical level of suspicion of malignancy in those particular nodules? Third, can you identify a higher PPV in nodules identified as suspicious with Afirma that had a higher percentage risk? In your table, the nodules that were 75% suspicious rather than nodules that were 50% suspicious. And finally, would your results be different, do you think, if you included or were able to include more of the Bethesda 4 nodules in your study? I really recommend this paper to the membership after it's published, and I want to thank the authors, Dr. Lyon, Dr. McHenry, for sending me the manuscript well in advance of the meeting. Thank you and congratulations.
Thank you very much. So to start, for the first question, if expanded molecular testing panels belong beyond the XA will increase positive predictive value. Theoretically, I think it could. With more information provided from the Afirma test, I think that the PPV would likely increase. And most importantly, I think that it could help delineate all of the suspicious nodules to help us give an idea of high suspicion versus low suspicion, which would hopefully help guide treatment, whether or not someone should go to surgery. For your second question, using the ThyroSeq. So the ThyroSeq is similar to Afirma in that it looks for genetic mutations and alterations. ThyroSeq actually uses DNA and RNA, whereas Afirma only uses RNA. Studies have shown no statistically significant difference in the sensitivity or the negative predictive value between the two. Both are good at ruling out cancer. One thing that I thought was interesting when I was looking it up is the cost difference between ThyroSeq and Afirma. It's actually shown on CMS that the Afirma is $3,600 more expensive than ThyroSeq. So I think it's something to look into the logistics of whether it's beneficial from that regard, especially in a safety net hospital like Metro Health. And then your third question, looking at the difference between the 75% risk of malignancy and 50% risk of malignancy, I think it's a great question and something that could be looked into for a larger study. Our sample size was smaller, so if we had tried to determine a PPV between those two groups, we wouldn't have been able to make any statistically significant conclusions because the sample size is so small. We did find that all the RAS mutations were scored as 75% risk of malignancy, which I thought was interesting. But as I mentioned in our slides, not all of the RAS mutations were found to be malignant in the end. And then lastly, do I think that there would be a different result in the inclusion of Bethesda 4 nodules? Absolutely. Bethesda 4 has a higher risk of malignancy or pretest probability of malignancy. The risk of malignancy in Bethesda 4 is between 25 and 40%, whereas in Bethesda 3, it's 20 to 30%. So I think that that would absolutely increase our PPV. Thank you.
It's open for discussion. We have time for one more question.
I just had a question as to the patients that had the high risk genetic mutations.
Mhm.
Did that change your operative management during, like when you took them to surgery? Like, did you still proceed with a lobectomy in those patients? or did you proceed with a thyroidectomy? And obviously, some of those patients were going to require a thyroidectomy if they had disease on both sides.
Right, that's exactly what I was gonna say. It didn't change our management specifically, but if they had disease on the contralateral side, then, we would move forward with a total thyroidectomy.
Great. Thank
Thank
you.
you.
The next paper is an additional candidate for Best Paper by a Surgeon in Training Award. Initial non-diagnostic treatment of melanoma, Christine Schmidt from Western Michigan University.
Good morning. My name is Christine, and I'm one of the general surgery residents over at Western Michigan in Kalamazoo. I just wanted to say thank you to everyone here, and thank you to Dr. McCahill also for helping with this project. And I'm going to discuss delayed biopsy in our melanoma patients in southwestern Michigan. I have no disclosures. So in terms of melanoma, when it's recognized at the early and localized stages, it can have a near 100% survival rate. And in the past literature, delays have often been attributed to patient-centered factors, whether that be limits in patient education that I think has greatly improved over the past few decades, or more melanoma that is harder to diagnose. The acromelanomas tend to be cited in many of the case series and case reports in the melanoma literature. In Kalamazoo in Southwest Michigan, we have our Melanoma Quality Outcomes Registry that includes patients from 2019 to 2025. And this is updated with patients as we continue to treat more melanoma cases. And in these cases, we identified some patients who were treated prior to any biopsy for lesions that later proved to be an invasive melanoma. And in more of the derm literature, they have been describing inappropriate initial treatments, particularly with cryotherapy, which we'll see in our study as well, as one of the potential points for future improvement in this field. And on the right, we have a picture of one of our patients in this case series who this was after treated with several rounds of cryotherapy over a few months, who then presented to our surgical oncology office with what later proved to be a nodular melanoma. So we had an observational study of patients who were treated for invasive melanoma from 2021 through 2025. And we had two groups, those who had the standard of care initial biopsy and those who underwent what we're defining as a non-diagnostic treatment. So any treatment of a cutaneous lesion prior to biopsy that was presumed to be a non-melanoma diagnosis. And this would include antibiotics, cryotherapy, topical agents, steroids, prior to that surgical biopsy. We wanted to look at depth at presentation stage, the time from when they initially brought the lesion to the attention of a healthcare provider, and the delay in time that they would get to a surgical oncology consultation for that definitive treatment. And using all these factors, we then looked at the treatment that was required, including the surgical margins of resection, as well as whether they qualified for adjuvant therapy. So in terms of demographics, our groups were fairly similar. And I do just want to point out that about 98% of our population was Caucasian. However, this is similar to the incidence in melanoma by ethnicity in the United States. And I wanted to start with a more qualitative picture of our results. So these were the 10 patients in our case series. And on the far left, you'll see that, similar to the dermatologic literature, 7 of these patients had cryotherapy. But then looking in the second column, while I do have, the statistics on the next slide, I think it's impressive to see that some people waited months or even over a year until they got a formal biopsy with a melanoma diagnosis. And then, the final right column, these aren't people just presenting to non-specialists. There's a wide variety of initial interactions with the healthcare field that people had this initial miss treated by. And so looking at our results table, the first row shows the statistically significant delay in time to a surgical consultation in our oncology office for those who had a delayed biopsy. And that did result in the third row in a greater Breslow depth at presentation of these lesions, as well as 5 out of 10 of our patients presenting with stage 3 or 4 disease, compared with only 15% of those who had an initial biopsy. And while the surgical margins required for their definitive treatment was not statistically significant, I would argue that nearly a half a centimeter difference in margins of resection does come out to, clinical significance on the patient, whether that be cosmesis or, if it's a digit, amputation of a digit and functional outcomes. And additionally, 7 of our 10 patients did qualify for adjuvant therapy. And, that's a year of treatment with the associated side effects, follow-up imaging, a lot more follow-up on the part of the patient in terms of, returning to office, and much more burden on the patients for that. And so, although this is uncommon, it was 3.7% of our patients. It did result in significant delays in surgical consultation, a more advanced disease stage, a higher utilization of adjuvant therapy and its associated side effects, and further treatments required. And, I think what really hits home is that 4 of our 10 patients have had a sustained melanoma, either recurrence or a death due to this melanoma. We can't say that it was from a delay in diagnosis, but a lot of them did present at that higher disease stage. And so, looking into the future, there's some promising data in the use of artificial intelligence, not as a replacement, but as just another adjunct that we can use, and not even to diagnose lesions, but more for better discernment on which lesions we should biopsy. It has even shown to be equivalent in some comparisons against dermatologists, and can sometimes be better than those who don't have a specialized education in evaluating these lesions and which ones should be biopsied. And so with that, I will say thank you, and I will open it up for questions at this point.
The discussant for this paper is Dr. Chung from Corewell Health and Michigan State University.
Good morning. I'd like to thank Midwest Surgical Association for giving me the chance to review your work. And I'd like to thank Dr. McHale for asking this important question, which is what happens to these patients? What is the clinical implications of a missed or delayed diagnosis of melanoma? I have a few comments and 4 questions. First comment is this. While we all strive to be perfect, we want to make the diagnosis first time around. None of us are able to do that. Having said that, your group actually made the right timely diagnosis in about 97% of the time. It's going to be really hard to improve on that. Just make a bad analogy. If you're baseball players, you would definitely be in the Hall of Fame, if not considered cheat codes.
That is fair.
2 out of the 10 patients had acral melanomas, which are very difficult to diagnose. If you got rid of that, your timely treatment or biopsy or diagnosis of melanoma in this group would have been 97%. And lastly, I really do believe even a skin biopsy, which seems like it's not a big deal, can come with potential issues. And the question we don't know is, what was the denominator? How many other patients presented to these providers from outside with some skin lesions that were treated appropriately? I don't think we would ever know the answers to that. So the first question is, of the 10 patients who had delay in their diagnosis, what were their initial presumptive diagnoses? I know what they were treated with, but I wonder what the presumptive diagnoses were. Of the 2 patients in that group with acral melanomas, what was their stage of melanoma? Was it stage 3 or 4? Thirdly, in the non-delay group, how many patients had acral or amelanotic melanomas, just to as a comparison? And finally, I know AI and dermoscopy and all that is available, but what are you doing to improve your impressive 97% timely care to 100% timely care in the future? Again, great presentation. I want to thank you for providing me with a manuscript well in advance of the meeting.
Thank you for those questions. So starting with the first one, of the 10 patients who had the delay, um, you know, treatment began sometimes 6 months or even a year after a year before they had the biopsy showing it was melanoma. Unfortunately, we tend to receive just the most recent records from the dermatology offices. And so that first encounter or treatment with that photograph of what it looked like initially was sometimes absent. But we were able to talk with some dermatologists in our community, and the most common presenting presumptive diagnoses would be for seborrheic keratoses, actinic keratoses, particularly on the head and neck region. And then they did mention basal cell as one of the presumptive diagnoses. However, that is also something that this would not be an indication for cryotherapy or not biopsying it initially. The second question, so the 2 patients who had the acral melanoma, the first one was stage 2B, and he actually underwent a toe amputation, a distal digit amputation. And the second patient was a stage 3 who had neoadjuvant pembrolizumab, but progressed locally, eventually required a transmetatarsal amputation of the foot, as well as an inguinal lymphadenectomy, and ultimately was staged 3D for the 2 acral melanoma patients. For the comparison non-delay group, there were 5 other acral melanomas that we found, and so our entire population that had 7 patients. And of the 5 additional acral melanomas, there were delays in biopsy greater than 6 months in those patients from the time it was first identified. However, they did not get any preemptive treatment prior to that biopsy, so that is why they were not included in this delayed treatment cohort of 10 patients. And I think the last question was how to improve on an already 97% success rate, which is a fair question. So, we're overall pleased with the timely care that we seem to have here. And I think, in our minds, we're trying to think of this as a never event, almost like a wrong side or wrong site surgery, and how there's metrics, there's timeouts, there's checkboxes and quality control measures to prevent those things from happening. We're already in talks with the dermatologists in our community, seeing who is treating these initially, how much oversight there is in the dermatology clinic, and trying to get a better sense, even if we don't have exact numbers, of what that true denominator is. Like you said, they're probably treating thousands of lesions on hundreds of patients with cryotherapy. And so, partnering with them more, I think, will help us to get a better idea moving forward.
Thank you.
Chris McHenry from Cleveland, Ohio. Dr. Schmidt, thank you very much. That was a well-presented paper. I just had 2 short questions. So first, who's doing the cryotherapy on the lesions prior to biopsy, number 1? And then number 2, have you looked at timing to your patients getting in to see a dermatologist as a factor in terms of outcomes? I don't know if you've ever tried to get an appointment with a dermatologist, but it's like, it's a long,
difficult,
long
yeah.
time. So those are my 2 questions for you. Nice job. Yeah.
Thank you. So I'm sorry, I just immediately forgot the first question. It was who is performing the cryotherapy. We did look into this. There are a wide variety of different healthcare providers who are performing the cryotherapy. It includes physicians, it includes PAs, NPs, primary care physicians. So, and in those offices, it's hard to tell from when I looked at the charts, whether it was the primary care physician or a PA or NP in that office. But we do know that there are, there could be an opportunity to provide some more oversight in these dermatologic clinics, which I think feeds into your second question. It's hard to get into a dermatologist. And we haven't looked at that specifically, but we have kind of talked about it colloquially outside of this. And, when you're waiting 7 months to look at a lesion, PAs and NPs are a great way to help, cut down that wait time. And so that's kind of the spot that we might be in figuring out how to improve the times and, just provide more care in Southwest Michigan. Yeah.
One quick question. Oop,
Yeah,
sorry.
Paul Wright, Grand Rapids. I applaud you guys at looking at this from a quality improvement standpoint. My question is about the comparator group. So in the 10, I'm sure you're looking at acrals, nodulars, which are diagnostic challenges. And even with timely diagnosis, they're usually associated with a greater depth. So my question is, in your comparator group, did you look at anything with pulling those subtypes out, comparing against the 10 to see if those differences were actually held up in terms of depth at diagnosis and stage, et cetera?
We have not, but I think that would be a very appropriate thing to do, and it looks like Dr. McCahill might have a response to that as well.
No, I'm the attending behind this idea, and I'm just, it's a very tough thing to, bite the hand that feeds you as a melanoma surgeon. I get, some of these are coming from very good offices, but I will comment, I just didn't see this in my first 10 years. And so I'm super concerned. I think I'm hearing more and more about dermatology offices with numerous satellites. The satellites are not staffed by physicians or dermatologists. And I really, my gut feeling is AI is going to be helpful here. I've been reading a bunch, I'm not an AI expert, but the AI papers I'm reading on pigmented lesions are, they way outperform they way outperform everything except experienced dermatologists. And I've grown to learn that these satellite offices there are no physicians. So I think this is part of the issue. And then private equity buying up all the dermatology offices is going to be more of a push to burn. And I feel we've identified a really big problem. So how to fix it, I don't know.
And I think there's at least one FDA-approved AI app now, which could be useful in terms of an access standpoint and cost effectiveness.
Okay, our next paper is Optimal Management of Fissure-Associated Fistulas, a Single Center Experience by Dr. Leinfeld. And this too, like all the other presentations, are up for best paper by a surgeon in training.
Good morning. My name is Dr. Hannah Liefeld. I am a general surgery resident at Corewell Health West in Grand Rapids. Thank you to the Midwest Surgical Association for allowing me to present our research. Anal fissures arise from local trauma to the anoderm, typically in the setting of extremes in bowel consistency and frequency. This, coupled with an environment of local ischemia, leads to a chronic scarred wound, thereby preventing wound healing. Bacteria and debris harbor within the recesses of these chronic anal fissures, leading to localized infection, then abscess, then fistula formation. However, only a small subset of these chronic anal fissures begets fistula formation, which leads to our question of the optimal surgical approach for anal fissure-associated fistulas. This begs the question, is fistulotomy alone sufficient enough to manage this problem? Or do we need to add the addition of a sphincterotomy in order to lead to complete healing of the sphincter? This is a single center retrospective cohort analysis comparing two surgical approaches, fistulotomy alone, or FA, and fistulotomy with sphincterotomy, or FS, for management of anal fistulas associated with anal fissures. We included adult patients who had a concomitant diagnosis of anal fissure and anal fistula who underwent surgical management during a 10-year period. We excluded pediatric patients, those with a known diagnosis of Crohn's disease, and patients who underwent surgical management outside of our institution. We primarily aimed to evaluate the efficacy and post-procedure complications of FA and FS. Our primary outcome was symptom resolution rate, while our secondary outcome was recurrence rate. Overall, we initially had 58 patients who were included in our study. After more careful review, we excluded an additional 4 patients based on the predetermined criteria, leaving us with 37 patients in the FA group and 17 patients in the FS group. In general, patients were within the age range of 40s to 50s, and the majority of patients who presented were males. Of note, the leading presenting symptoms for both groups was bleeding and pain, definitely significant overlap between fissure-related symptoms and fistula-related symptoms. Of note, 53% of patients in the FS group had a smoking history, whereas only 22% in the FA group had a history of smoking. And then in general too, 41% of FA patients had previous anal rectal surgery, while no patients in the FS group had a history of previous anal rectal surgery. 54% of patients presented with an intersphincteric fistula in the FA group, whereas 77% of patients in the FS group presented with subcutaneous fistulas on presentations. This corresponded to a significant difference in fistula type at the pre-op or in the operative evaluation. The majority of fissures were located posteriorly, consistent with the literature. It's notable to mention that there were no significant difference in 30-day complications, symptom resolution, recurrence, and average time to recurrence between the two operative groups. There was a low 30-day complication rate for both types of surgical procedures, and there was a high symptom resolution rate for both types of surgical procedures as well, 84% for the FA group and 85% for the FS group, respectively. This is a Kaplan-Meier graph demonstrating time to recurrence for both operative groups. The FA group is denoted by the blue line and the FS group is denoted by the green line. 9 patients, or 29% of the FA group, eventually had a recurrence compared to 2 patients, or 15% in the FS group. This did not, however, correspond to a significant difference. The mean time to recurrence was 34 months for both groups, with a range of 3 to 101 months post-procedure for recurrence. As far as fissure-specific recurrence goes, only 4 patients in the FA group had fissure-specific recurrence, whereas 1 patient in the FS group had fissure-specific recurrence. Among these 5 patients, 4 of them were managed medically successfully. When analyzed independently, smoking history, previous anal rectal surgery, and fistula type ultimately did not have any effect on symptom resolution rates. We ultimately found no significant difference in symptom resolution rates, 30-day complications, recurrence rates, and fissure-related recurrence. Taken all together, we posited that control of the fistula is a key step in surgical management of fissure-associated fistulas. In order to avoid the risk of incontinence related to sphincterotomy, we posited that medical management of anal fissures could be useful adjunct to fistulotomy. Prospective studies comparing the effectiveness of fistulotomy alone versus fistulotomy with medical management would be compelling. As fistulotomy alone is successful in managing most of these patients, it is difficult to discern the role of sphincter hypertonia and the role it plays in this pathologic insult. Measuring sphincter tone before and after surgical management may provide further insight on pathologic insult. Finally, previous anal rectal surgery and fistula type potentially play a role in surgeon decision-making. However, this ultimately did not influence symptom resolution rates for us. Given the retrospective design, single center nature, and limited sample size due to the rare pathologic phenomenon, this could limit the generalizability of our results. In addition, the procedure type was ultimately determined by surgeon, leading to potential selection bias in our study. We did not have any measures of preoperative sphincter length and tonicity, as well as degree of sphincter involvement during the fistulotomy. Future prospective studies are needed to validate our findings and establish an algorithm for the management of fissure-associated fistulas. In conclusion, 30-day complications, symptom resolution, and recurrent rates are equivalent between fistulotomy alone and fistulotomy with sphincterotomy. Fistulotomy alone can be considered a viable option for the management of fissure-associated fistulas. Thank you.
This discussion will be led by Dr. Stewart.
Patients, Dr. Liefeld, and to save time for questions from the floor, I'll limit my comments to simply 4 questions for you. Number 1, you provide important information regarding similarities between the 2 groups. However, you also share that FA patients more often presented with bleeding, whereas most FS patients presented with pain, and that 15 patients, all of whom who received FA, had a history of anorectal surgery, which included a remote history of surgical sphincterotomy and even fistulotomy. How do you feel this affected a surgeon's decision between FA and FS And how do you feel this may have affected the outcomes that you shared with us today? Number two, were you surprised that none of the fistulas were transphanteric, given that the fistulas ostensibly arose from an anal fissure? Number three, do you believe that 23% of FS patients not returning for follow-up potentially influenced your assessment of safety for that surgery? And then lastly, would your team consider combining sphincterotomy with a lift procedure, which would address the concerns about incontinence that arise with the FS approach? Thank you.
Thank you, Dr. Stewart, for your thoughtful questions. I may need some help remembering those questions, so I apologize. The first question, I believe, was related to the very obvious dichotomy between FA patients receiving previous anal rectal surgery versus the FS patients not receiving previous anal rectal surgery in the past. I would imagine that the surgeon's decision-making at that point would be related to not doing a sphincterotomy due to previous potential manipulation of the sphincter in the past, leading to kind of more of a less is more approach in this method. Your final question, which I remember, is combining sphincterotomy with lift procedure in order to avoid that significant risk of incontinence related to sphincterotomy. As far as what I would posit based on the results of our study, in addition to doing the fistulotomy, I would initially recommend medical management in conjunction with the fistulotomy, as that tends to have a high success rate as well, instead of doing more procedures to the patient. If we can get by with just medical management as well, I would advocate for that. And then I apologize. Oh, one of your questions was related to not seeing any transphanteric fistulas in this patient population. We were very surprised by that finding as well, especially just given the nature of having a fissure being associated with this fistula, or associated with the sphincter, my bad. And I really don't have any other way of explaining that other than, yes, we were surprised by that finding.
Mark Hill, Chicago. Did you, in any of these patients who underwent sphincterotomies, did any of them obtain Ceton at all?
I'm sorry, did any patients who underwent the sphincterotomy
Sphincterotomy.
with fistulotomy, did any of them get a Ceton in addition to
Correct.
that?
Right.
Not for the patients specifically in the study at the index surgery. However, there were 4 patients who did recur in the FA group alone. And any of them that had a recurrence of their fistula, I believe 3 of them ultimately received a Ceton at their second operation.
Thank you.
Any further questions? All right, thank you.
Thank you.
Sorry, need the button. Next paper is bedside exploratory laparotomy, mortality predictors and clinical implications in critically ill patients. There's a change. The presenter is Matthew Morris from Corewell Health, Michigan State.
I'm happy to present today as Dr. Aubrey just had his first child. All right. I don't have any disclosures this morning. And to be just to discuss the procedure itself. So bedside exploratory laparotomy is an uncommon but heroic intervention, typically reserved for critically ill patients with a suspected intra-abdominal pathology who are unable to be transported to the operating room due to hemodynamic instability. At our hospital, common indications have included suspected bowel ischemia, intra-abdominal hemorrhage, abdominal compartment syndrome, and fulminant colitis. Though we always proceed with the intent of saving a life, previous studies into this intervention have revealed mortalities ranging between 77% and 83%. Which can be directly compared to patients who are able to get to the operating room for these indications often have mortality of about 45%. given a paucity of work on the subject, we elected to further explore the mortality rate of a bedside exploratory laparotomy, as well as the preoperative predictors of mortality, with the intention of guiding clinicians in making compassionate and ethical choices for patients and their families who are faced with a grave circumstance. Our study was a single center retrospective review of patients admitted to both, or I guess to the medical, surgical, cardiothoracic, and neuro ICUs at Butterworth Hospital in Grand Rapids, Michigan. We're a level 1 trauma center, as well as a tertiary referral hospital for a large network in West Michigan. Our patients were 51 consecutive patients admitted to or seen in consultation by the acute care surgery group between 2017 and 2024. These patients were further divided into cohorts based on survival to help identify predictive factors of mortality. We excluded semi-elective washouts and fascial closures, as well as patients undergoing these procedures who are, because these patients are often not in extremis, if undergoing this electively. We also excluded pediatric patients who underwent bedside operations and any patients who received the intervention prior to transfer. Ultimately, 51 patients underwent a bedside exploratory laparotomy. 9 patients survived to discharge. 42 died in hospital, giving us a bedside or exploratory laparotomy mortality rate of 82.4%. And most importantly, no patient over the age of 70 was able to survive. Our patient's mean age was at 58.3, just for some context there. To dive a little bit more into the preoperative characteristics of our patient panel. You can see in boxes all of our categories that we found to be significant. This is an abbreviated table of the preoperative characteristics. But overall, our patients were majority male with an average age of 58.3 years compared to non-survivors. Survivors had a significantly younger age and were lower on the Charlson Comorbidity Index scale. Also statistically significant in our case were preoperative lactate and preoperative pH. Factors that did not end up bearing any significance were sex, BMI, vasopressor use, renal replacement therapy, AKI, prior operations, mechanical ventilations, blood counts, and ECMO support. Post-operatively, we'd like to note that there were pretty similar times of operation between both groups. Of the 9 people who survived, 6 had no significant intraoperative findings, while 40 of the 42 who died did have an intra-abdominal pathology that contributed to their hemodynamic instability. Of these who passed away, a quarter of the patients had global bowel ischemia. Over 50% had segmental ischemia. There was a patient with a small bowel perforation and 3 had abdominal compartment syndrome. Of those who lived who had intra-abdominal pathology, there was a patient with hemorrhage, a patient with segmental ischemia, and a patient with a small bowel perforation. Post-operatively as well, the patients who lived had significantly lower lactates and blood pH. And blood pH trended towards significance. The rates of mortality did differ between the patient's initial locations. So for the SICU, that's where most of our patients were drawn from, but they had the lowest mortality. There were higher rates of mortality from the medical ICU and cardiothoracic ICU. Our only patient from the neuro ICU did pass away. This plot here is a swimmer's plot of all of our patients depicting time to death postoperatively. Our median time to death was 18 hours, and 38 of the 42 patients were dead within the first 24 hours postoperatively. Of course, our study is limited by its retrospective design. We're kind of not a unique hospital, but a unique hospital in the, I guess, bigger picture, where we have an acute care surgery model where we can bring the operating room to us at any hour of day or night. And our sample size was too small for multivariable analysis. Of course, our patients are also drawn based on attending judgment at the time operation. In conclusion, our study did demonstrate that our survivors were younger, had fewer comorbid conditions, and had less severe preoperative metabolic derangements. The presence of intra-abdominal pathology was strongly associated with mortality and age as well. These are pretty similar results to previous studies. And I think most importantly, they push us to help define futility. A lot of families, of course, ask us to do everything, and we hope that in frank discussions, we can be clear with the implications of doing everything and who might benefit from not doing everything. Not all doom and gloom. Certainly there may be an indication for trauma patients. And as we look forward, we'll think more about patients selection. I think our work will help us guide some of the more frank discussions with patients and their families. Thank you.
Standing behind you, I get the privilege of discussing this paper. It supports my personal bias. As an acute care surgeon, I always hated operating in the ICU. It's not as big, it's not as organized, and you may be able to bring a team, but it's not the operating room itself. My questions are, the surgical patient, the non-surgical patients that were in the MICU or the neuro ICU, how were they identified? And was there a time when perhaps they didn't need a bedside laparotomy and they could have maybe more timely consult, maybe they could have been gone to the operating room? My other question is, do you have anesthesia come from the OR to do the cases, even though it's in the ICU? Because sometimes the argument is, well, we'll do it in the ICU because the OR doesn't have room, but usually the OR can find room, they just don't have staff. And I hope you continue with the discussions with families, because everything to different people means different things. And if there's any chance when we offer people an operation, we think that they might recover and leave the hospital. And so I think that's the most important point from this paper, and I applaud you for that.
To answer your first question, there was not a statistically significant difference in time from admission to time to the operating room in patients who lived or died. I don't remember if there was specific breakdown for MICU cardiothoracic ICU. Our hypothesis, at least, for why those patients didn't do as well is a generally higher comorbidity burden and a different indication for a lot of those patients who've had cardiac procedures to have than bowel ischemia. To answer your other question, in the times I've been involved in these procedures at our hospital, we always have an anesthesiologist available to come up from the ICU. At least with our model previously, they've had, I think, 3 call people. So a person who's in hospital, a person who's, I think, in hospital until a certain hour of night, and then a person who can be called in from home.
Please excuse my inquisitiveness, but once you made the decision to operate at the bedside of the ICU, how long did it take you to get the troops up to the ICU to start?
Again, speaking from personal experience, it's usually a matter of about 20 minutes, I would say. But I don't know for the entire cohort of patients. Thank you.
Peter Hollowell, Charlottesville, Virginia. Very nice presented paper. Takes me back to my second month as a resident at Metro, walking into the ICU, and there's a laparotomy going on. And I said to myself, this is what I want to be doing. Changes over time, though. But my question to you is, of the deaths, how many of these were you're opening the belly and you're getting an answer? So you found ischemic bowel and now you can say, we're done. And you give the family an answer and instead of spending hours deliberating about it.
Sure. Um, Based on the percentages of the type of intra-abdominal pathology, I would guess about half to 3/4 were opening, getting our answer, and telling family, this is probably it. I think the plot that indicates the median time to death and the course of each individual patient as well indicates that for most patients, it was a matter of an hour or two before they expired, indicating that we probably had a discussion afterwards and compassionately extubated and allowed them to pass peacefully.
So I wanted to compliment you on the good study. I think that futility and conversations of end of life are one of the many challenges we face that are difficult with family. But to spin this around a little bit of a different way, you know, there were people who did survive. And I think that taking this literature and the previous literature that you guys have reviewed may be valuable to give cutoffs more so than just saying this is a good or bad thing that we do. So more so as a comment and a question is, have you guys considered sort of looking at your data and other data to sort of guide surgeons in more of an algorithmic approach of, you know, maybe this is somebody where you tell family, look, this just isn't worth doing, rather than just sort of commenting on the mortality?
Yeah, sure. I think my personal practice, you know, after I am an attending, this is a problem presented to me, I wouldn't offer it for a patient over 70 or with a lactate above 8. As far as sort of clinical practice, I think it would be interesting to develop a protocol for our hospital since this is a not infrequent consult for us. So.
Marshall Baker, Salt Lake City. I mean, I think this sounds to me like people are going off a cliff and then you jump in. I mean, and you're looking back at the cases and trying to dissect them. And it's an opportunity, I think, to identify what should have been done differently. I mean, a lot of these are going to go through M&M processes and things like that. But my question is, where is it? What is it that we should be doing? Should these have had interventions earlier? Should they have gone to the OR sooner? You know, I feel like the last thing you want to do is to go to the OR in the ICU or to go to make an incision in the ICU. You want to see this coming and avoid it. Is that what happened, or is it not the case that that's what happens? Does that make sense? Like, how do we?
Yeah,
How do we get that?
I can only speak from my personal experience with it, but typically, I guess I've encountered it when people sort of have the coagulopathy that's going to cause a decline we can't fix. Some of the times when we get the consults for it from other ICUs too, it's we weren't involved in their care and we just get the call and go up there and it's time to go or not. So yeah, that's a great question. I think I wish we had that granularity to look into.
Larry McHale, Western Michigan. So I really applaud the authors for doing this. I run M&M at our institution. I've often sat back and said, this is because we're seeing all the mortalities. And I said, this is crazy. But you identified some survivors, so that's great. But the corollary is my question. They weren't as sick and they didn't have any pathology in 6 of them. I think there was nothing found or around that number. It was 66%. So were they well enough to get to the OR? I mean, is some of this has got to be judgmental that like, oh, I got to do this at the bedside. Do you?
Yeah, that's a great question I wish we could answer. But I think for those patients, in addition to their age and their I have to imagine that they were hemodynamically unstable to the point where they couldn't get to the OR, but they weren't metabolically deranged in comparison to the group who perished.
All right, thank you. Our next paper is determination of impact of prior abdominal surgery on outcomes of a pancreatic duodenectomy procedure by Dr. Smith.
Good morning, and I am a second-year resident from Cornwall. So today we will be talking about pancreatic adenocarcinoma, and as many of you know, it is a highly morbid diagnosis. It is currently responsible for the third leading cause of cancer-related mortality in the United States. And it's also in the top 10 worldwide. Currently, our treatment options for pancreatic adenocarcinoma include chemotherapy, radiation, and surgery, which has proved the only curative treatment option to date. Specifically, in this review, we were looking at patients who were diagnosed with pancreatic adenocarcinoma of the head, which is managed with the Whipple procedure. And while at high volume centers, this procedure has a relatively low mortality rate, the morbidity rate of this procedure is relatively high in the literature, cited at approximately 50%. In the literature, there is very few documentation and studies investigating the role of prior abdominal surgeries in our patients who we are now going to take for a Whipple procedure. There are two contemporary studies that are included on this slide that have attempted to look at this impact. And one of the studies says that many prior abdominal surgeries is associated with negative outcomes after Whipple, whereas the other study shows that it has no impact. And thus, we sought out to investigate at our institution the role of prior intra-abdominal surgery in our patients who are now going to proceed with a Whipple. We performed a single center retrospective review for patients who underwent a Whipple by two surgeons at our institution between the times of 2017 and 2024. We included all patients who were greater than 18 years of age and excluded patients who were either pediatric patients or patients in vulnerable populations, such as pregnant patients or those who are incarcerated. And in order to risk stratify our patients, we developed a novel stratification scoring system in which we risk stratified patients based on laparoscopic surgery or not. And so those who had laparoscopic surgery, either no intra-abdominal surgeries or laparoscopic pelvic surgery, such as like a appendectomy, those patients were graded as a 0, whereas patients who had laparoscopic upper abdominal surgery, such as a cholecystectomy, would be graded as a 1. And then patients who had open abdominal surgery were given a score of either a 2 or a 3. And the differentiator was if patients had open upper abdominal surgery, such as an XLAP and a Graham patch for perforated peptic ulcer, those patients would be graded as a 3 as opposed to a 2. This is the summary of our stratification. We had just shy of 300 patients that we included in the study, with a majority of our patients being given a grade of a 0 or a 1. When looking at our preoperative characteristics, we had relatively even numbers of male and female in both groups, with an average BMI amongst all stratification scoring systems of about 27 to 28. Almost all of our patients are referred to a surgical optimization center before they're taken to surgery. In the premorbid conditions like smoking and diabetes are hopefully optimized before we proceed with a Whipple, and those were also relatively the same between groups. Intraoperatively, we found that there was no statistically significant difference in the increase of operative time or estimated blood loss, despite patients being categorized as a 0, 1, 2, or a 3. And the only statistical significant difference that we found, which is relatively unsurprising, is that patients who have more invasive intra-abdominal procedures were found to have more adhesive disease at time of surgery. Postoperatively, all of our patients did relatively well, and there was no statistical significant difference between complications that we investigated after proceeding to the operating room, despite patients being categorized as a 0, 1, 2, or 3. Our mean postoperative stay was about 8 to 9 days, with patients averaging about 1 day in the ICU if requiring ICU stay at all. And there was no statistically significant difference between pancreatic fistula, delayed gastric emptying, or surgical site infection. In addition, postoperatively, we looked at wound dehiscence, abscess, TPN requirements, postoperative transfusion, and reoperation, and there was no statistically significant differences between our groups. When looking at our readmission rates and our mortality rates, once again, there was no statistically significant difference in readmission rates at 30 days and at 90 days between our groups. However, when looking at the numbers, we did note that there was an increase in mortality noted in our SIS group 3 with comparison to the other groups at 90 days. And this was the only statistically significant difference that we found. There are some limitations to this study, although there is almost 300 patients included. It is a retrospective design, and so inherently it includes selection bias and also limits our data completeness. Also, there's patients who are included in the study who had surgeries that were done outside of our state, outside of our center. And so reviewing their operative notes or their surgical history can sometimes be challenging if we have incomplete documentation in order to appropriately risk stratify patients between whether it's group 2 or 3. And we also are a very high volume center. And so the 2 surgeons who were included in this review perform Whipples regularly. And so this is something that we are relatively experienced with dealing with at our institution. In conclusion, I don't think that this retrospective review changes our practice in that it doesn't tell you whether you're going to take a patient to Whipple or to not. But it really helps to guide your preoperative discussions with patients and just letting them know that you are more likely to have increased adhesive disease at time of surgery, and that we need to take special precautions to prehabilitate these patients prior to proceeding to the operating room. Thank you very much, and I'll take questions at this time.
Dr. Cox is going to start the discussions.
Hello, Eric Cox, University of Illinois, Peoria. Thank you to the Midwest Surgical Association for the opportunity to review this paper. It was a very well-written paper, and you did a very fine job recognizing and addressing the limitations of the study, leaving me very little to critique here. Having said that, these were all open procedures. And since there's really no statistical findings other than that 90-day mortality, which in your manuscript you list the causes of those, which seem very unrelated to the prior surgical procedures done. Could this be better applied toward stratifying patients that may be successful in a minimally invasive approach to their Whipple versus outcomes, long-term outcomes, like you said? And also being a single center study, you mentioned the generalizability to lower volume centers and such. Have you looked at being able, can you apply this scoring system to a broader database like NSQIP? Is that a feasible thing to do as well? Again, thank you very much and very nice paper.
Thank you. I'll have to, Dr. Aubrey did a large part of the work and he's not here today. I'm stepping in for him, so I will pass that along. I think first, yes, in part, we could definitely apply to minimally invasive surgery. With the growing number of robotic Whipples that are being performed nationally, we could apply this and it would inform you about, one, is it feasible to start laparoscopically or robotically in a minimally invasive fashion? And it can give you a better ability to predict whether you will have to convert to open in patients who have more significant adhesive disease. And two, the scoring system is a novel system that we developed at our institution. We use the scoring system for cytoreductive surgery as a basis for creating our scoring system. And I think it would be a very interesting question to try to study the scoring system and validate it with a larger data set. I think that would be an excellent question to investigate in the future.
Any further questions? Yes.
Very nicely presented study. It's very interesting. I mean, the scoring system you do pre-op, is that right?
Yes.
Is there any thought to doing something like, I mean, I feel like the guys in Grand Rapids, right, are incredibly experienced. You see the times are the same from complex prior surgery to none, basically, right?
Yeah.
I mean, to me, that tells me they're great surgeons. They're very experienced, can work through the adhesions quickly. I wonder if the scoring system should be something you apply in the OR. Like, are there people that you get there and you find the adhesions are horrible, or there are many other problems, like this is stuck to that, and that may be something that leads you down the road toward a different conclusion. The other thing I thought was interesting to me was the idea of sending all these guys to you called it an optimization center. Like I was wondering, what was that? Because in my former life, where I'm fielding people from the suburbs of Chicago, people felt obese but relatively tuned, plugged into healthcare. Now I'm receiving people from Montana and New Mexico, and I'm like, whoa. The idea of an optimization center makes a lot of sense. Like go there for a month, come back to me. But I mean, I just wondered what that was like, what that meant. So. thanks.
Yeah, I think to address your first question, it would be interesting to use a scoring system to estimate adhesive disease in the operating room. However, I can foresee that some of these patients receive radiation before surgery. Some of these patients have neoadjuvant chemotherapy, and I think how stuck together things are, for lack of a better word, would also be impacted by those factors outside of just their surgical history as well. So we did not look at adhesiolysis time in this study. So whether patients required 20, 30, 60, 90 minutes. So that's definitely something we can delve into the future. And just a note about our surgical optimization center. It's a clinic that we have available to us in Grand Rapids where patients who are undergoing complex procedures or those who have a BMI above X can all visit. And they do a thorough chart dive and perform all of the scoring risk calculating systems and make recommendations about a number of things, whether it's weight loss, insulin, patients who are on warfarin and have all types of blood thinners and things like that. So we are very, very fortunate to have that clinic available to us to help optimize our patients.
About half of our patients come from FAR too. So we make sure they have a hemoglobin A1C stop point. They all have to stop smoking for 4 weeks. And then we try to have them walk at least 2,000 steps to be able to qualify for surgery. If they're seen outside and clear that they're wherever they're coming from.
Great, thank you.
Thank you.
The next paper is neck hematoma after parathyroidectomy. It's presented by Marie Sue from Metro Health Medical Center.
Hi, everyone. I'm Marie. I'm a PGY2 at Metro Health. I'll be presenting our work on neck hematoma after parathyroidectomy. We have no disclosures. Hematoma is a well-known, potentially life-threatening complication of neck surgery. It's less frequently studied after parathyroidectomy when compared to thyroidectomy. This is largely because it occurs less frequently due to a more limited tissue dissection and vessel ligation. Additionally, patients with renal hyperparathyroidism are thought to have a theoretical higher bleeding risk due to qualitative platelet dysfunction and the need for hemodialysis. This raises questions about whether this group may be at increased risk for postoperative hematoma. The primary aim of our study was to calculate the rate of neck hematoma after parathyroidectomy, and our secondary aim was to evaluate whether renal hyperparathyroidism patients have higher rates of neck hematoma when compared to patients with primary hyperparathyroidism. This is a single institution retrospective cohort study. Patients were identified from a prospectively maintained database, which included patients who underwent parathyroidectomy by a single surgeon between 1992 and 2025. Descriptive statistics were used to characterize the study population, and the rate of postoperative neck hematoma was determined for the entire cohort and compared in patients with primary hyperparathyroidism and renal hyperparathyroidism using bivariate analysis. We defined neck hematoma as postoperative bleeding that required urgent evacuation. We had 1,002 patients in our study who underwent parathyroidectomy during our study period. 84% of our patients were female with a median age of 60 years. 922 patients had primary hyperparathyroidism and 80 had renal hyperparathyroidism. 6 of our patients developed hematoma, and they developed a need for surgical evacuation a median of 32 hours after their parathyroidectomy. The median ASA score of patients who developed neck hematoma was slightly higher than the rest of the cohort, but this was not a statistically significant difference. This table summarizes the hematoma rates across various patient subgroups in our cohort. The incidence of neck hematoma requiring urgent evacuation was 0.6% in the entire study cohort. It was 0.7% in patients with primary hyperparathyroidism, and it was 0.6% in patients with primary hyperparathyroidism who underwent parathyroidectomy alone. No patient with renal hyperparathyroidism developed a hematoma. The incidence of neck hematoma was not higher in patients who underwent subtotal or total parathyroidectomy. And in patients who had a concomitant thyroidectomy, the incidence of neck hematoma was 1%. This was the highest incidence of our patients. It's not unexpected because the risk of hematoma is higher with thyroidectomy when compared to parathyroidectomy. This table is a summary of the characteristics of the 6 patients who developed hematoma. Of note, all 6 patients had hypertension as a comorbid condition. 5 of 6 were on either an anticoagulant or an antiplatelet agent, and 5 of the 6 patients had an ASA score of 3. So this study is an expansion of a previous analysis from our institution from 2008 that looked into neck hematoma causing respiratory compromise after both thyroidectomy and parathyroidectomy. At that time, over 350 patients underwent parathyroidectomy and none developed neck hematoma. Since then, we've added over 600 more patients to our cohort, and our study affirms that the rate of neck hematoma in patients who undergo parathyroidectomy is low. Our findings are consistent with rates of hematoma that are reported in large database studies. A study using the nationwide inpatient sample had a 1.1% hematoma rate, and a study that used the Collaborative Endocrine Surgery Quality Improvement Programs database had a 0.3% hematoma rate. Of note, our findings do contrast with other studies that found a higher hematoma rate in patients with renal hyperparathyroidism. Nastos et al. Had a higher complication rate in their renal hyperparathyroidism cohort, which included a significantly higher rate of hematoma of 2.5% across their renal hyperparathyroidism patients. And Tang et al. Found that patients with secondary hyperparathyroidism had highest overall complication rates, including a hematoma rate of 1.3%. Our study had several limitations. It was a retrospective review of a single surgeon experience and therefore may not be generalizable to other practices. Our small number of hematomas makes it difficult to identify any significant risk factors for hematoma, even in a high volume practice. And finally, our relatively low number of patients with renal hyperparathyroidism precludes us from identifying a difference in neck hematoma between patients with primary hyperparathyroidism compared to renal hyperparathyroidism. In summary, neck hematoma after parathyroidectomy is rare. It occurred in just 0.6% of our patients, and we found no significant difference in hematoma rates between patients with primary hyperparathyroidism and renal hyperparathyroidism. Thank you for your time. I'll take any questions.
The paper will be discussed by Dr. Chudnovsky from the University of Kansas School of Medicine, Wichita.
Thank you. As we all know, efforts to evaluate and mitigate surgical complications are critical to ensuring patient safety and improving surgical outcomes. The authors are to be commended for addressing the issue of hematoma following parathyroidectomy, a serious but rare complication. As the authors note, the small sample size makes it difficult to draw broad conclusions, but I have a few questions. All 6 patients had a history of hypertension. Were these instances of controlled chronic hypertension, or did the patients experience perioperative spikes? Were you able to identify that? Knowing whether this was simply a comorbidity or an acute contributor could inform perioperative management strategies. Also, how many total patients in your cohort had hypertension? This would help us interpret relative risk. Another key observation was the 5 of 6 patients with hematomas were on anticoagulation therapy. How many total patients were on anticoagulation therapy? And did you look at medications holding time and if that contributed at all? You also mentioned after your paper that parathyroidectomy is increasingly performed in ambulatory settings, and this study reinforces that that could be safe. Considering your data, how would you modify or reinforce ERA's protocols to support safety for same-day discharge? Since the majority of your patients' hematomas occurred 32 hours after your surgery, so they would probably be at home by then. And finally, would you consider this surgeon to be a high-volume surgeon? And if other surgeons who are not as high volume were performing these surgeries, would that alter your ERAS protocol and potentially not allow the patient to go home that same day? Thank you very much.
Thank you. So for your first question, hypertension was identified as a past medical history risk factor for the patients who did develop hematoma. It's not actually a part of the data that we keep in our database. So unfortunately, I can't make a conclusion about whether specific blood pressure did contribute to hematoma. Similarly, we don't keep information about whether a patient is on anticoagulation for every single patient in the database. It was just identified for the 6 who developed hematoma. But we do have protocols for holding anticoagulation for all of our patients. Warfarin and Plavix are held 5 days prior to surgery. Aspirin and all NSAIDs are held for 7 days, and DOACs are held for 3 days. We delay restarting all anticoagulation and antiplatelet agents for at least 48 hours after surgery. And for our patients on dialysis, we have heparin held for the first dialysis session after their surgery. And then next question was about ERAS protocols. So our patients who undergo parathyroidectomy have this procedure performed as outpatients. They're allowed to eat right after surgery, and we have them stay in our post-anesthesia care unit for a routine stay of about less than 2 hours. They have a neck check done by a member of the surgical team prior to discharge, and they're given strict return precautions as well as a phone number to reach the on-call resident when they discharge. And for our patients, that seems to work fairly well. It is true that some patients, the median hours for presentation was 32 hours, but patients presented with their hematomas and were all able to make it to the operating room for their evacuation. No one required urgent evacuation in the emergency room or on the floor. Dr. McHenry is a high volume thyroid and parathyroid surgeon. I think for lower volume practices, it is perhaps hard to say if the rate of hematoma would be higher, given that it's such a rare occurrence overall for these patients. It's reasonable to consider for surgeons who are not comfortable with discharging their patients from the PACU, or if there are anesthesia concerns, to keep them for an overnight stay.
Abid Hawasti, Detroit, Michigan. Interesting presentation, and it's a very interesting topic, but the question I have for you is that thyroidectomy is really more important in neck hematoma, life-threatening condition, because bilateral usually, and that's what's compromised the breathing. If you eliminate these patients who had concomitant thyroidectomy from your study, would that affect your data? And most of these patients who are total thyroidectomy, usually they're admitted. And they're not discharged home the same day, at least in my practice. But how many of these were in your data that required admission? And the last question is, usually the problem that occurs is in the operating room when they're trying to extubate a patient and they buck on the tube, and most of these hematoma, at least in thyroidectomy, are presented in the recovery room or on the floor within 24 hours. Do you have that data extracted? But I'm sure it's difficult to find from anesthesia records.
So 209 of our patients had concomitant thyroidectomy. 2 of our 6 patients who developed hematoma had a concomitant thyroid lobectomy. And so for our lobectomy patients, they have a longer PACU stay of 4 hours before their neck check and discharge home. 2 of our patients did actually have their hematoma identified before leaving the operating room. So they were transferred to their bed, about to be rolled, and then promptly transferred back for their evacuation. I do not recall if they were patients who had thyroidectomy, but yeah, it's definitely, it makes a difference. Yeah.
Eliminate the thyroidectomy to make it more clear data.
Mhm.
I think would be a better
Yeah.
picture than to include the thyroidectomy with your
Mhm. Excellent point.
Steve DeYoung from Loyola. Nicely presented paper, a difficult topic, not a lot of patients to draw conclusions from. I'm just wondering, over the time span of your study, obviously, we've all changed our technique a little bit. Was there uniformity in terms of things like routine placement of hemostatic agents within the neck, use of harmonic scalpel and so forth? Were there other things that were entered into or introduced into the equation that might have had an impact on your data? Did it look differently in terms of maybe the early half of your data collection as opposed to the second half? Second question is, can you surmise if there would be a difference between a unilateral parathyroidectomy or a bilateral exploration in your patient population? Thanks. Very nicely done.
Thank you. This may be a better question for Dr. McHenry, but I believe that there were differences between the earlier patients in the study compared to later. There were certainly differences that I noted in how patients who had neck hematomas were managed post-operatively following their evacuations. From my limited experience, we treat these patients the same, but I'll defer.
So a couple comments. First of all, Dr. Su presented that when you excluded the patients who had thyroidectomies, that our rate of hematoma was still 0.6%. So there is that. There were roughly, 180 patients who had thyroidectomy, which we parsoned out, and you saw that the rate was still about 0.6%. Have I changed over my career, things that I do? Yeah, I mean, the harmonic scalpel now is, I routinely use that, but I don't think that's really changed the hematoma rate, to be honest with you. That's just anecdotally. Other things that I've changed, that's probably really the only thing that I can think of that's been of really significance. I think that just anecdotally, it's hard to predict which patients are going to develop hematoma. These patients, you're not taking major vessels. And we've not seen any difference, back to Dr. DeYoung's question, whether you do a unilateral or a bilateral procedure in these patients. And we parceled that out as well and didn't see a difference in terms of neck hematoma. So what I gathered from this is you just have to have a high index of suspicion, and it's hard to predict which patients are going to develop this. Even when we do the things that we've done, I think the avoiding heparin use in the initial dialysis in patients with renal hyperparathyroidism is a significant, or at least intuitively, anecdotally, a significant factor. But the thing that I gather from this, it's hard to predict which patients are going to develop hematoma. So just a quick reminder, all the papers prior to this are papers that are up for best paper by a resident and or surgeon in training. Our last paper is by a medical student, I believe, correct? All right. And it is maintaining equipoise between challenging short-term and desired long-term outcomes of metabolic and bariatric surgery. Dr. Ibrahim.
Thank you. Good morning, everyone. My name is Musa Ibrahim. I'm a fourth-year medical student at Western Michigan University in Kalamazoo, and I have the pleasure of presenting on maintaining equipoise between challenging short-term and desired long-term outcomes of metabolic and bariatric surgery. No disclosures. Obesity is an epidemic in the United States. 40% of the adult population is classified as obese, which poses significant challenges in terms of both health and costs. Metabolic and bariatric surgery remains one of the most effective long-term treatments for obesity. And the three main procedures we want to talk about today are laparoscopic sleeve gastrectomy, Roux-en-Y gastric bypass, and biliopancreatic diversion with duodenal switch. While duodenal switch offers the greatest potential long-term metabolic benefits, it's also associated with more risks. Sleeve gastrectomy is generally safer in the short term, but has a less impactful metabolic effect. And Roux-en-Y gastric bypass kind of strikes a balance between the two. So despite this, there's been a relative paucity of rigorous comparative short-term safety data. And as the landscape of obesity management continues to evolve with the advent of GLP-1s and newer procedures such as the SADI, there's a need for a robust comparison of short-term safety among procedures, which was the focus of our study. So sleeve gastrectomy is one of the most commonly utilized bariatric procedures due to its relative simplicity and ability to be used as a bridge to other surgeries. Its major drawbacks are worsening GERD and lower metabolic impact, as I mentioned. Room-wide gastric bypass offers more durable weight loss and better control of obesity-related conditions, but it carries risks such as dumping syndrome and micronutrient deficiencies. So biliopancreatic diversion with duodenal switch effectively combines these two components. So it's sleeve gastrectomy and an extensive intestinal bypass in which a larger portion of the small intestine is circumvented. So with this significantly shortened common channel for mixing with bile and pancreatic enzymes, there's a dramatic reduction in nutrient absorption. And this technique provides the most potent metabolic effects, particularly for patients with severe obesity and type 2 diabetes. But it also carries a higher risk of complications and malabsorption, requiring strict lifelong nutritional follow-up. So we conducted a retrospective analysis using data from the ACS-NSQIP database spanning from 2005 to 2017. We focused on short-term 30-day outcomes, including morbidity and mortality. Some secondary outcomes include readmission, reoperation, operative times, and length of stay. So to ensure fair comparisons, we used pairwise propensity score matching with a caliper width set to 0.002 for tight matching. And we did have two matches. So first, we matched duodenal switch patients with gastric bypass. Then we matched duodenal switch patients with sleeve gastrectomy. We then combined these two matches, removed the duplicates to obtain matched triads. So in our statistical analysis, we compared the three groups with gastric bypass used as the reference group, i.e. set to 1, and our categorical and continuous variables were analyzed as shown. We used logistical regression and then applied to calculate adjusted odds ratios for complications. And Bonferroni correction was used to control for type 1 error. This slide just shows the trends in bariatric procedures during our study period. So as you can see, rates of gastric bypass start to increase around 2005 with a modest decline in bypass and increased utilization of sleeve gastrectomy around 2013. Rates of duodenal switch, however, remained relatively stable throughout the study period. And here is our final sample, which included over 188,000 patients. After matching, we had about 2,100 patients in each group. And as expected, duodenal switch was the least common procedure, comprising just about over 1% of the overall cohort. So here we have a table of the demographics and comorbidities of the three groups. So before matching, you can see that nearly all factors are statistically significant, which you don't want, with the greatest comorbidity burden in the duodenal switch group. And then after matching, we see that baseline differences were largely eliminated, ensuring fair comparisons. And I know this is another busy table, so I've highlighted the main 30-day post-operative outcomes that we want to discuss. So starting with 30-day mortality, we see that both duodenal switch and gastric bypass had a 0.8% mortality rate, while sleeve gastrectomy had no observed deaths. So though mortality was rare across all groups, this difference was statistically significant, favoring the safety of sleeve gastrectomy. Moving on to overall morbidity, duodenal switch had the highest rates at 10.2%, significantly exceeding both gastric bypass and sleeve gastrectomy. And it also had nearly double the rates of serious complications compared to gastric bypass, and substantially higher minor complication rates across multiple categories. And when looking at secondary outcomes, duodenal switch had the highest rates of unplanned reoperation, readmission, operative times, and longest median hospital stay. So this logistical regression shows the likelihood of each outcome considering gastric bypass again as the reference group. So we see that sleeve gastrectomy was associated with significantly lower odds of multiple complications. Specifically, the odds of serious morbidity were 39% lower than sleeve gastrectomy, with sleeve gastrectomy. For overall morbidity, the reduction was even more pronounced, with a 44% lower and significantly lower odds of minor complications. So, and also mortality was rare overall, and lower in the sleeve gastrectomy group, though this did not reach statistical significance. Sleeve gastrectomy consistently demonstrated the most favorable short-term safety profile, with lower odds of morbidity, infection, and readmission and unplanned reoperation compared to bypass. Now turning to duodenal switch, compared to gastric bypass, we found that duodenal switch, again, was associated with significantly higher odds of multiple complications. Most notably, the odds of serious morbidity were 79% higher, and odds of overall morbidity were 69% higher. And minor morbidity was also significantly elevated. Mortality was slightly higher in the duodenal switch group, but this did not reach statistical significance. And in terms of secondary outcomes, duodenal switch was associated with an increase in odds of readmission, reoperation not statistically different from bypass, but taken together, duodenal switch showed the highest burden of short-term complications. And here's a forest plot highlighting the relative odds of key 30-day outcomes for sleeve gastrectomy and duodenal switch using, again, gastric bypass as the reference. Overall, sleeve gastrectomy consistently showed the most favorable short-term outcomes, so lower odds of readmission, reoperation, overall complications, and serious morbidity compared to gastric bypass. The trend also suggested lower mortality, though the difference was not statistically significant. So in contrast, biliopancreatic diversion with duodenal switch was associated with increased risk across nearly all complications. And patients undergoing duodenal switch had a higher odds of readmission, complications, and serious morbidity. So these trends again reinforce the idea that sleeve gastrectomy offers the best short-term outcomes, while duodenal switch, though effective long-term, carries the highest immediate post-operative risks. So some limitations of our study. First, duodenal switch had a much smaller sample size compared to the other procedures, which could affect the robustness of comparisons, which was also a benefit of using the propensity score matching. Second, the study span of 2005 to 2017, which is not taken into account how practice patterns have likely changed since then. Third, we were limited to 30-day outcomes, so we didn't really capture long-term effectiveness or late complications. Also, reasons for readmission were often missing, especially in the earlier years of the database. And finally, causes of mortality were not specified, so we couldn't assess whether those were related to the procedures. Despite these limitations, the findings provide important insights into short-term safety across bariatric procedures. To summarize, sleeve gastrectomy offers the best short-term safety profile. Room-wide gastric bypass offers a middle ground in terms of both risk and benefits, and duodenal switch remains a viable option for patients with more complex medical profiles. Even after matching and adjustment, duodenal switch was associated with higher complication rates, underscoring the importance of careful patient selection. Ultimately, choosing the right bariatric surgery requires balancing short-term surgical risks with long-term metabolic benefit. For patients where duodenal switch is appropriate, rigorous preoperative optimization is essential to mitigate these risks. And as newer treatments change the obesity treatment landscape, data like ours remain critical for surgical decision-making in conjunction with tools that can be used to predict morbidity and mortality for each of these bariatric procedures. And I'd just like to thank Dr. Saad Shabrain for supporting this project, and Dr. Hawalsi for being the invited discussant and reviewing the manuscript, and MSA for allowing me to give this presentation. So thank you.
Dr. Hawassi, you open the discussion.
I really want to congratulate you on taking the topic with a lot of statistics analysis as a student. I went through your manuscript and it's amazing. Your work has been great. This is a well-structured and informative study. I appreciate the use of the large validated database and the rigorous propensity matching approach to compare the three major bariatric procedures. The finding on short-term morbidity, particularly the higher complication rate of the biliopancreatic diversion and the favorable outcome of the laparoscopic sleeve gastrectomy are clinically relevant and timely. It confirms what's already been stated in the past, where it's not surprise why the number of percentage of biliopancreatic diversion is 1.1% of the population, because that has been recognized back early in the 2000s. And as you all know, the sleeve gastrectomy was born out of the high risk of the biliopancreatic diversion, where they switched from that and used only the first portion of the operation, which became the sleeve gastrectomy. I didn't really know which what was your title of the topic. You switched it.
Yeah.
You presented a different title than the manuscript that you gave.
Yeah, we did update the title.
And I think
for
the
manuscript.
title on the manuscript should probably be the one to be used than what you use here, because you did not have any long-term data
Mhm.
where your title supposed to implement that there's some data. You focused only on the 30 days. And I think maybe we should change what you have in your manuscript to put the only short-term results.
Yeah, absolutely.
I'm going to give you the questions one by one so you don't have to.
Okay, great.
Be
Thank
easier
you.
probably. So in patient selection, did your analysis identify any patient subgroups for whom the laparoscopic, or actually you changed also on the manuscript. You mentioned here biliopancreatic diversion as an open procedure. In the manuscript, you mentioned laparoscopic procedure. So was it really an open or was it laparoscopic?
It was laparoscopic, yeah.
Because the manuscript says excluded, here it did not mention, it did not mention laparoscopic.
Yeah,
Okay.
it was laparoscopic.
So in this data, despite the higher short-term risk, did you exclude patients with laparoscopic sleeve gastrectomy as a second procedure?
Did we exclude?
Patients who did you exclude from your number the biliopancreatic diversion as a second procedure, that they had a sleeve first and then they continued to have the biliopancreatic diversion as a second procedure?
No, those patients were included in the.
Were included as a biliopancreatic diversion?
Yes.
Or that means you eliminated half of the procedure as a complication, as a risk for complication. So they did not have a sleeve at the same time of the biliopancreatic diversion.
Yeah, so.
You want to go to the microphone so we can all hear you?
The ACS endoscope database, not for the bariatric, for the general surgery, they did not specify if the case was converted from sleeve to different procedure. So it is just, we use the code and it's different patients. So every group has different patient. It is not someone that has sleeved and converted to duodenal switch.
Like a year later, what I'm saying, like a year later, they had the sleeve.
It's
They had
very
the sleeve
hard.
a year ago. Now they have biliopancreatic diversion as the secondary
Correct.
procedure.
It's-
Because that makes a difference.
Correct,
These
but-
patients now, their BMI is not the same.
Correct.
And the comorbidity is not the same.
Yeah, it is very hard from the ACS transcript data, even with 274 variable to find that.
Okay. The second question, do you think the complication rate with the biliopancreatic diversion reflect inherent procedure risk, or could this be mitigated by restricting the procedure to high volume fellowship trained centers?
Yeah, I think the procedure itself is inherently more complex, so longer operative times, more anastomoses, greater degree of malabsorption. So naturally increases the risk of complications. So I think some of the observed morbidity may reflect surgical expertise or institutional experience. I think it's reasonable to think that restricting it to those types of institutions, so like fellowship trained bariatric centers could help mitigate some of those risks, but unfortunately, that's not something that the NSQIP database captures, like surgeon volumes or fellowship training or institutional accreditation. So we weren't able to directly assess that. But nonetheless, these limitations certainly could have a consideration when taking into account the complication rates.
And given that your data ends really in 2017, how do you think the rise of the newer procedure of the CD procedure might impact the interpretation of relevance of your finding today?
Yeah, so like you said, with the data ending in 2017, it's before the widespread adoption of the SADI, which I think was in 2018 or 2020, and also the advent of like the GLP-1 receptor agonists. So both have significantly altered the landscape for obesity treatment. I think the SADI is kind of a simplified alternative to duodenal switch with similar outcomes and may be more favorable at some centers. But I think the metabolic surgery overall still will remain the most effective long-term option for severe obesity and refractory disease. And then I think these findings just provide kind of a relevant baseline for comparison for these in the future. I think SADI will require more like long-term observation to see its effectiveness.
And last question, based on your results, would you recommend the sleeve gastrectomy as the default procedure for most patients? Or do you see specific clinical scenarios where the Roux-en-Y bypass and the biliopancreatic diversion should still be considered first line?
Yeah, I think sleeve gastrectomies, obviously favorable risk-benefit profile may be suitable for many patients, particularly those with fewer comorbidities and patients who prioritize lower surgical risks. But we're not advocating for like a one-size-fits-all model. Gastric bypass remains preferred for patients with severe GERD or marginal weight loss after sleeve gastrectomy or who have poorly controlled diabetes. Duodenal switch should be considered for patients maybe who have higher BMIs or who have severe metabolic conditions associated with their obesity. Ultimately, the best procedure will depend on individual risks, the goals of the patient and their comorbidities. And our data should inform, not necessarily dictate kind of what decision is ultimately made.
Good job.
Thank you.
Since it's our president, I'll let him conclude our discussion here.
Thank you. Very, very well presented. Just interested in your comment. The BPD procedure is 1%, and where we see this big dive in mortality rates with gastric sleeve, gastric bypass, the surgeons performing it throughout the country are having many reps at this. So this procedure at just 1%, perhaps as it grows, we're going to drive those complications and mortality down. In your data set, was there any ability to see the people who are doing the BPD? Was that a program that were doing 100 a year, or was it somebody doing 2 or 3 or 4 a year?
Yeah, the data set didn't really discuss surgeon expertise. So it's not really something that we were able to analyze, but certainly a consideration in complication rates.
Remember, this was a fourth-year medical student who needs a job next year.
All right, for our next invited lecture, the Heritage Lecture, Bill Harridge was a man of uncommon energy, integrity, and honesty. His personal enthusiasm